Hello, this is Aaron Timms, third-year medical student from Boonshaw School of Medicine. This article that we're covering is cervical IC occlusion versus pseudoocclusion at CTA in the context of acute stroke and accuracy, inter-observer and intra-observer agreement study. The original article was by Angie Diouf and her colleagues. So the purpose of this was to evaluate the diagnostic accuracy and reliability of CTA to distinguish true cervical internal carotid artery occlusion from pseudo-occlusions in the settings of acute stroke. So they were referring to, with true occlusion, a true cervical carotid occlusion with a concomitant intracranial embolus, or a tandem occlusion. And by pseudo-occlusion, they define that as an isolated intracranial thrombus that impedes ascending blood flow. So looking at this from Radiopedia to get a little bit of a better grasp, the tandem occlusion refers to the simultaneous presence of the high-grade stenosis or occlusion of the cervical ICA and thromboembolic occlusion of the intracranial terminal ICA or its branches. Usually this affects the MCA, but in the context of this particular study, we're talking about the ICA and that T branch where it splits into the ACA and MCA. And this does have implications for endovascular clot retrieval, as it needs to be that proximal clot will need to be transversed in order to access the distal clot as well. Likewise, carotid pseudoocclusion refers to the apparent occlusion of the cervical ICA on CTA or DSA due to a stagnant column of unopacified blood proximal to the terminal T junction occlusion by thromboembolism. So effectively, that's talking about where we have this clot right there, and because of that, where it branches off into the external and internal carotid, this winds up just pulling up and not moving. So when we release the contrast, it winds up stagnating to some degree here and giving the illusion that we have a clot here and possibly a tandem occlusion, when in reality, the significance of this clot, where it doesn't have an outlet on either side, just leads to stagnation in this region. So this is showing it actually in CTA and DSA. We have the flame-like appearance here. We're looking at the DSA, and we can see the continuation of the ICA. When the wire is fed through, it actually doesn't hit resistance in this area and instead continues on until in the clinoid area it finally hits that resistance. So back to the original article. The materials and methods for this particular study: 7 clinically active readers, including 5 neuroradiologists and 2 interventional neuroradiology fellows, independently reviewed CTA images of patients who had undergone mechanical thrombectomy and had pre-procedural CTA. Only the age and the sex of the patient were provided, and this is because the study writers believe that this is going to be available to the radiologists, so we're not going to make their job harder. We're going to see how they would be if this were a real patient. The readers were then tasked with assessing whether there was true or pseudo cervical ICA occlusion while blinded to the final DSA results. Their results were compared with DSA as the final reference standard. Sensitivity and specificity for detecting the TO, as well as accuracy and diagnostic odds ratio, were calculated with inter and intra-observer kappa statistics. Cervical ICA, the pseudo-occlusion occurred in 12 of 37 patients, 32.4%, with non-attenuation of the ICA on the symptomatic side. Inter-observer agreement coefficients did not reach the substantial value of 0.61 for either pairs or groups of the readers. They also did intra-observer agreement studies, and for 2 of the 3 highest scoring participants, when they tested using the same images 2 months later, these 2 retained substantial intra-observer agreement, 0.72 and 0.75. The third scored just below the substantial cutoff. So the averages for the cohort, sensitivity wound up being around 68%. You can see the range there. Specificity, 75%, and the diagnostic odds ratio was about 8. And there was only fair inter-observer agreement, 0.32. So the overall conclusion, all of this is to say that in the context of acute ischemic stroke with ipsilateral non-attenuation at single-phase CTA, even specialized radiologists may not reliably distinguish true occlusion of the cervical ICA from pseudo-occlusion. So what does that mean for our patients? Well, the diagnosis of ipsilateral cervical ICA occlusion in the context of acute stroke should not be performed on the basis of CT angiography alone. It may affect neurosurgery's decisions regarding materials that they're preparing for surgery, which can increase costs if they're anticipating that there is a tandem occlusion and it turns out there's only the distal occlusion, and it can also potentially affect patient outcomes. Lack of attenuation of the ipsilateral ICA at CTA in the context of acute stroke should be correlated by other imaging methods so as to not erroneously affect clinical decisions. The authors advise interventional neuroradiologists to make a final decision on the basis of the DSA images performed at the start of their procedure. Alternatively, 4-dimensional CTA that shows the time progression as well has been shown superior to single-phase CTA for differentiation of true occlusion and pseudo-occlusion. 4D MRI contrast-enhanced angiography is promising, but it's also time-consuming for time-sensitive decision-making like you have to do in stroke. Some of the limitations of the study, they did acquire their image retrospectively. The study itself was done as a primary study, but they didn't do it as patients came in. They looked back in their version of EPIC, if you will, and got their patient images that way. They did have a small sample size as well. I think that, as we mentioned earlier, the questionable, is this a tandem occlusion or is this a pseudo-occlusion, was around 37. They mentioned they potentially had selection bias, but this was possibly minimized since they drew their relevant patients from their institution, or they drew from all the relevant patients at their institution, which they argue would make it fairly representative of the population eligible for thrombectomy. They did not exclude cases in which TPA was given after CTA but before DSA was obtained, but they argued that since the time was about an average of 63 minutes between these two, they are confident that it wouldn't have a significant effect on their results. Finally, their readers came all from the same tertiary center. So just to kind of wrap this up, concluding as they concluded, this is a quote from their article. In the context of acute ischemic stroke with ipsilateral ICA non-attenuation on single-phase CT angiography, even specialized radiologists may not reliably distinguish true cervical occlusion from pseudo-occlusion because inter-observer agreement is not substantial, and CT angiography interpretation is often discordant with DSA. Therefore, diagnosis of cervical carotid occlusion should be made with care in correlation with other imaging modalities, such as angiography or 4-dimensional CT angiography, may be necessary so as to not negatively affect clinical decision making. So thank you all very much for listening. These are my references, and I hope you enjoyed.